Good morning, I'm Dr. Tamer, a lecturer of OBGYN, Faculty of Medicine, Cairo University, Qasr Al Aini, and a fellow of the American College for Obstetrics and Gynecology. I'm going to give you today a presentation about fetal heart tracing and a brief about PARTOGRAM. The first thing that we should know about fetal heart tracing is some definitions, and we'll look on some figures and pictures to see what I'm talking about. The first thing is going to be the baseline. The baseline of the fetal heart is the rounding to increments of 5 beats per minute during a 10-minute segment. So the baseline is not stable in the fetus, which is normal due to the fighting between the parasympathetic and sympathetic nervous system, which are not mature in the fetus. The baseline, normal baseline, is about 110 to 160 beats per minute. Above 160 is called tachycardia. Below 110 is called bradycardia. When we see the baseline, it should be for a minimum of 2 minutes in any 10-minute segment. Otherwise, we cannot say the baseline, and it's judged as indeterminate. The second definition, which is the most important thing in the tracing or fetal heart tracing, is the variability. The variability is basically the fluctuation in the baseline that are irregular in amplitude and frequency. The normal is what we call moderate, which ranges from 6 to 25 beats per minute. And that's also explained by the domination of the parasympathetic and the sympathetic immature centers of the brain of the fetus. The normal is, as we said before, is a variability, moderate variability between 6 to 25 beats per minute. Minimal, absent, is abnormal. Marked also is abnormal. The take-home message in this slide and actually in the whole presentation is that the variability is the most important thing in the tracing. If you have a moderate or normal variability in the tracing, that means that the baby CNS is intact and the baby is not acidotic. If you have absent variability, this means that this baby most probably is acidotic and already there is an insult to the brain. Also, marked variability is not a good sign, and it's a sign of hypoxia. This is a slide showing what is meant by minimal variability. You can see it's a line. There is no variability at all. It's about 150 baseline. Acceleration basically is the apparent abrupt. The key point here is abrupt increase, which means that the onset to peak is less than 60 seconds in the fetal heart rate. At 32 weeks and beyond, which is expected like in full-term babies, to see the acceleration as 15 beats per minute with a duration of 15 seconds, something we call 15 times 15. And it should be at least 15 seconds and not more than 2 minutes. Below 32 weeks, meaning in the preterm babies, it can be 10 times 10. Prolonged acceleration, meaning that it continues for 2 minutes or more. If it continues more than 10 minutes, then this is what we call change in the baseline. This is a slide showing normal variability, accelerations, The baseline here is about 150, and there is multiple accelerations, as you can see on the slide. Then we go into the definitions of deceleration. The first definition is what we call early deceleration. Early deceleration is called early because it occurs early with the contraction. Okay, it's basically a mirror image of the contraction, and it doesn't have any pathological significance. It's just due to compression of the fetal head. When there is compression of the fetal head as the head is passing through the birth canal, early deceleration happens due to vagal stimulation. Okay, so it's gonna be a mirror image of the contraction. You're gonna see a symmetrical gradual. The key point here is gradual decrease and return of the fetal heart rate associated with a uterine contraction. In most cases, the onset nadir means that the lowest point, and the recovery of the deceleration are coincident with the beginning, peak, and end of the contraction, respectively. As you can see, here is an example of early deceleration. Okay, this most probably in the second stage of labor. Then we go into late deceleration. Definition of late deceleration. Late deceleration happens with being late or after the apex of the contraction, or after the contraction has started. Okay, so it's not a mirror image of the contraction, and it denotes that, or it signals hypoxia or ischemia to the baby, meaning that there is insufficient blood going to the baby, like in uteroplacental insufficiency, and it's visually apparent, usually symmetrical, and the key point here is gradual, also decrease and return of the fetal heart associated with a uterine contraction. And in most cases, you're going to see the onset, nadir, and recovery of the deceleration occurring after the beginning, peak, and ending of the contraction, respectively. As you can see here, this is late decelerations, and you can see here that they are happening after the contractions, and then returning back to the baseline, and then when there's a contraction and there is some ischemia, it happens again and again and again. Variable deceleration, okay, it's the most common deceleration you can see, and it's basically due to umbilical cord compression. And the key point here is going to be abrupt decrease in the fetal heart, and the abrupt fetal heart decrease is defined as from the onset of the deceleration to the beginning of the nadir of less than 30 seconds. Okay, and it can be associated with the uterine contraction or not associated. Okay, and they are commonly variables, meaning that they vary in shape, size, duration. Okay, and that's why they are called variables. You can see here the variable deceleration. Then there's another two definitions. One is prolonged deceleration. Okay, prolonged deceleration meaning that the decrease in the fetal heart is more than 2 minutes but less than 10 minutes, because if it's more than 10 minutes it's going to be a change in the baseline. Another very worrisome and ominous sign is called sinusoidal pattern. Sinusoidal pattern, this is seen in hypoxic fetus. Is visually apparent, smooth sine wave-like undulating pattern in the fetal heart rate baseline with a cycle frequency of 3 to 5 per minute, which can persist for 20 minutes or more. Here you see a slide of what we call prolonged deceleration. You can see here that it starts with late deceleration, and then the baby couldn't compensate, and it started into prolonged deceleration and going into bradycardia. The next slide is about a sinusoidal pattern. You can see the sine wave, okay, and this denotes hypoxia. What we are saying here, okay, is the American College guidelines. If some of you are reading from the Royal College, the nice guidelines, they're gonna have some differences. According to the American College, they categorize the tracing into 3 categories: category 1, 2, and 3. 1 is the normal. Okay, so the normal tracing, you're gonna have a baseline rate of 110 to 160, moderate variability. The early deceleration is gonna be present or absent, because we said that early deceleration has no pathological significance. The late or variable decelerations, they're gonna be absent. The accelerations, they're gonna be present or absent. And of course, category 3 is going to be the pathological, what the Royal College say as pathological. And the category 2 is the worrisome, okay, category, in between 1 and 2. So 1 is the normal, okay. 2 is abnormalities in the baseline, like bradycardia, not accompanied by absent baseline variability, or tachycardia, or changes in the variability, either minimal variability or absent variability with no recurrent deceleration, or marked baseline variability, or absence of induced acceleration after fetal stimulation, or periodic deceleration, recurrent variable deceleration accompanied by minimal or moderate baseline variability, prolonged deceleration more than 2 minutes but less than 10 minutes, recurrent late with moderate baseline variability, variable deceleration with other characteristics such as slow return to baseline, overshoots or shoulders, what some people may say as atypical variable. Category 3, which is the pathological or the abnormal tracing, or is the absent baseline fetal heart variability, and recurrent late deceleration, recurrent variable deceleration, and bradycardia. Also, sinusoidal pattern is considered as a category 3. So how do we manage category 1? Basically, there is no management for category 1 because it's normal, so it's going to be just observation, okay, or monitoring. It's a normal tracing, no fetal acidemia, continuous or intermittent monitoring. It's usually half an hour in the first stage and every 15 minutes in the second. What about category 2? Category 2, you need to evaluate and initiate appropriate corrective measures when indicated, with continuous surveillance and re-evaluation. The tracing is a dynamic process, meaning that you can have category 2 with some measures, it can goes into or return back to category 1, or if these measures didn't solve the problem, the category 2 can progress into category 3. So the presence of acceleration, whether spontaneous or elicited by digital scalp, and the moderate variability are both highly predictive of normal fetal acid base status, and when you see them on the tracing, even if it's category 2, it's reassuring, okay, and it gives you some time to do some corrective measures. Obviously, the management of category 3, okay, is going to be prompt delivery. So now we're going to talk about the causes and the management of different deceleration. As we said before, that intermittent variables is the most common deceleration. The term recurrent, if it's recurrent variable or recurrent late, mean that it occurs with more than 50% of the contractions. And in intermittent variables, they usually don't affect the acid-base balance of the baby. It doesn't donate any hypoxia, so it often doesn't require any treatment, and they are associated with normal perinatal outcomes. If you have recurrent variable deceleration, you have to see the frequency, the depth, the duration, and other fetal heart rate characteristics as the variability. If the variables are becoming more and more deeper or taking more time, then this means that there is an impeding acidemia, that the variables are are progressing, and acidemia will occur in the future. The whole management of recurrent variables should be directed at relieving the umbilical cord compression. Once we relieve the compression, there will be no more variables. This can be accomplished by maternal positioning and amnioinfusion. Basically, amnioinfusion is injecting some saline into the uterus, okay, through a special catheter. Unfortunately, we don't have this here in Egypt. Recurrent late deceleration. So the recurrent late deceleration reflects transit or chronic uteroplacental insufficiency. Most common causes can be maternal hypotension, especially after epidural anesthesia, uterine tachycystole caused by excessive oxytocin or administration of prostaglandins like Cytotec, and maternal hypoxia. The management is going to be or include lateral positioning to relieve the to improve the venous return, intravenous fluids, bolus in the case of hypotension, oxygen administration, and evaluation of the tachysystole. If it's oxytocin, then we should stop the oxytocin, give her more fluids to wash out the oxytocin. If there's late deceleration in the setting of minimal variability and absent acceleration, this means that acidemia should be considered. Also, fetal tachycardia. Fetal tachycardia is, as we said in the earlier slide, that it's a baseline heart rate greater than 160 for at least 10 minutes. It can be caused by infection from the baby or the mother, like in chorioamnitis, pyelonephritis from the mother, pneumonia. Any other maternal infection can cause fever and fetal tachycardia. Also, some medications like terbutaline. Terbutaline is a medication given for uterine relaxation, and sometimes they can be also medications for asthma. It can cause reflex tachycardia. Drug abuse like cocaine and other stimulants. And if the maternal medical disorders like in hyperthyroidism, or if there is obstetric condition like placental abruption or fetal bleeding and fetal tachyarrhythmia. Tachycardia per se in isolation is poorly predictive for fetal hypoxemia or acidemia unless it's accompanied by minimal or absent fetal heart variability or recurrent deceleration or both. When we see fetal tachycardia, we should think about what's the cause of the fetal tachycardia. If it's an infection, We treat the infection. If we treat the infection, most probably the tracing will revert into a normal baseline, and you will see the fetal heart rate going from 160 or 170 down into 140 and 150. Right? Bradycardia and prolonged deceleration. Fetal bradycardia is defined as a baseline heart rate less than 110 for at least 10 minutes. Prolonged deceleration is more than 2 minutes and less than 10 minutes. This can be seen in maternal hypotension after a patient takes an epidural, if there's sudden umbilical cord prolapse or occlusion, complete occlusion, or if there's rapid fetal descent, or a placental abruption or uterine rupture. Minimal variability can be seen in some situation like a fetal sleep cycle, or most importantly in fetal acidemia, and of course with some medication like magnesium sulfate taken for preeclampsia and eclampsia, and opioid and drug overdose. In case of the opioid take, the minimal variability usually improves within 1 to 2 hours from the intake of the medication. The sleep cycle is usually 20 minutes, but doesn't last more than 60 minutes. Continued minimal variability in the absence of acceleration or normal scalp pH cannot be explained or resolved with resuscitation, should be considered as a potential indicative of fetal acidemia. Tachysystole or uterine tachycardia is defined as more than 5 contractions in 10 minutes, average over 30 minutes. The presence or absence of associated fetal heart rate abnormalities is a key issue in management. If there's no fetal heart rate abnormalities, usually we don't do anything. If there is, then we should intervene. Intervention is usually by stopping the medication or trying to stop and reverse the medication that caused the tachysystole. In category 3, there is an increased risk of neonatal encephalopathy, cerebral palsy, and neonatal acidosis. What we usually do is resuscitative measures, which include maternal positioning, stopping any medication that we think that it contributes to the problem, oxygen, examination of the patient, and preparing for delivery in a timely fashion. In some cases, immediate delivery in a woman with an unknown duration of a category 3 tracing may not improve the outcome. Because usually the fetus has already experienced a hypoxic ischemic injury, but still, we deliver the baby as fast as we can. Usually the decision to incision interval and the mode of delivery should be based on the timing that best incorporates maternal and fetal risk and benefits. As part of monitoring labor, we talked about the fetal heart monitoring. Also, we use the PARTOGRAM. A PARTOGRAM is a graphic record of the progress of labor and the relevant details of the mother and fetus. It was initially introduced as an early warning system to detect labor that's not progressingly normally. And we can diagnose from it arrest of labor, delay of labor, and actually it increased the quality and regularity of the observation made on the mother and fetus. And it also serves as a one-page visual summary of the relevant details of the labor. Basically, the PARTOGRAM, is a graph where we put all the details of the mother and the fetus on it, and we can see the progress of labor through one look on the graph to see if this labor is going smoothly and it's progressing, or if there's any problem with labor. And this is a figure of the WHO PARTOGRAM, and it's divided into the fetal heart tracing, the examination, the mother, the contractions, everything. And the items that we usually put is the maternal well-being. We record the pulse every 30 minutes, blood pressure and temperature every 4 hours, urine output, the whole things for the maternal well-being. Also the fetal well-being in the term of the fetal heart rate, the liquor, the uterine contraction assessment, the abdominal examination, and the vaginal examination. But that slide, we finish our presentation.